Welcome back, everybody. David here again with Med School Boot Camp. So in this next chapter, we're going to talk about a group of very important arthritis conditions called seronegative spondyloarthritis. We'll talk more in the next slide about what it means to say something is seronegative and what that is referencing. So in this video, we're going to talk about all the high-yield ones I want you to know, including psoriatic arthritis, ankylosing spondylitis, IBD-associated spondyloarthritis, and reactive arthritis. There are other ones that can be included in this category, but these are the four most common ones that they're likely to ask you about on test day. So in this video, I just want to do a little bit of an overview. What is a seronegative spondyloarthritis? So let's break down the word a little bit. Spondyloarthritis is a group of inflammatory conditions that typically affect the vertebral column. When we say that these conditions are seronegative, we're talking about the pathophysiology here, and that these chronic inflammatory conditions are negative for rheumatoid factor. That's what we mean when we say that it's seronegative. It does not have, the serum does not have, it's negative for the rheumatoid factor. And if you recall, the rheumatoid factor is an anti-IgG antibody. So if you draw your attention over here to this image, it shows us that rheumatoid factor is typically an IgM autoantibody. Remember, IgM is the one that's the pentad. It's composed of 5 different components versus something like an IgG molecule, which would be a standalone component. Also keep in mind things like IgA. Remember, the unique thing about that one is it's typically a dyad. There's 2 components to it, and that we would actually have 2 antibodies that are linked to one another. And so these are good ways to think about how do we categorize these? Is it a single antibody like IgG? Is it the double antibody, typically the IgA? Or is it the pentad, typically the IgM? Now, these IgM autoantibodies bind to the Fc portion. Remember, this is the singular component of the antibody itself that then breaks off into kind of 2 separate areas over here. This is the Fc portion of an IgG antibody that's being bound by the IgM antibody. And so that's just a little bit of a refresher of what is rheumatoid factor and how does it play a role in the pathophysiology here. Now, for the purposes of board exams, they really like you to know this connection right here, and that is there is a strong association with HLA-B27. So a lot of these conditions that we're going to talk about in upcoming videos have a strong association with HLA-B27. Some of them more than others, but exam writers want you to know that when they give you this indication, right, they say the patient had genetic testing, results came back positive for HLA-B27, they're trying to get you to narrow down your differential to these key ones right here. Again, there are other things, this is not all inclusive, but these are the highest yield ones that they're going to ask you about on test day. Now, when we think about the common presentation here, it's typically going to be more common in men compared to women and in a younger age, so patients less than 45. Again, this is not always the case, but most commonly on board exams. It's also important to know that patients are often going to present with non-specific constitutional symptoms. So these include things like fever, fatigue, maybe some weight loss. Again, these are not super specific. There's a lot of things that can be associated here, but it's really about reading the full question and taking these symptoms along with the other clues they give us to answer the question that they're asking. Now, you can probably imagine these patients are going to have arthritis, right? This is called a spondyloarthritis. It's right in the word. But the way this presents can be different depending on the condition that they have. It depends on which one we're talking about here. But classically, it's going to present with asymmetric oligoarthritis. That is to say, it's asymmetric, so it's not equal on both sides. We think about things that might be symmetric arthritis, like rheumatoid arthritis, where both of the hands might be affected. But asymmetric means one or the other might be affected. One knee, not the other knee. One hip, not the other hip. These are examples of asymmetric arthritis. Oligoarthritis means more than one joint is going to be involved. So when we talk about the different types of arthritis, you can have monoarthritis affecting one joint. You can have oligoarthritis affecting many joints. Polyarthritis, which is affecting all joints, or most of the joints at least. Now, we also want to think about some other things that we would expect to see with arthritis findings, such as pain and stiffness. This is typically worse in the morning. Some other unique findings they might ask about include things like dactylitis. And again, we'll talk about this in a little bit more detail in each video as they come up. But dactylitis is essentially inflammation of the fingers or toes. You can get something called sausage-like digits. And this can be seen in a variety of different arthritic conditions, such as rheumatoid arthritis, and even some other conditions such as sickle cell disease or even sarcoidosis. They might also describe something called enthesitis. And this is talking about inflammation at a point where tendon attaches to bone. So a very classic one is going to be the Achilles tendons. You can imagine you have the calcaneus bone right here, and you have the Achilles tendon going up the back. Enthesitis would really be talking about inflammation that's building up kind of at this junction, right, where the Achilles tendon attaches to the bone. This is sometimes also called an insertional tendinopathy as well. So again, be on the lookout for this as a classic finding when you're talking about seronegative spondyloarthritis, or they're presenting this in a question stem. Now, one other important thing to keep in mind is ocular findings. The most classic one they like to ask about is uveitis, right? Inflammation of the uvea in the eye. And this is important because when they're giving you question stems, they're not just going to give you all the obvious symptoms, right? They're not just going to say HLA-B27 and talk about, some of the vertebral column findings that we're going to talk about in upcoming videos, which are kind of classic pathognomonic findings. They're going to kind of give you a mixed presentation. They're going to throw in some of those unusual presentations, some ocular findings. They might be wanting you to think about other conditions that can have uveitis, such as sarcoidosis. And then you're going to have to use all of the clues to narrow down and decide what is the best answer, what is the most likely pathology the question writers are trying to ask you about. So all of these things are going to be talked about more in detail. We're really going to focus on the key types here. That includes psoriatic arthritis, ankylosing spondylitis, IBD-associated spondyloarthritis, and reactive arthritis. Again, this is not an all-inclusive list. These are just the most high-yield ones, the ones that are most likely to show up on test day, and those are the ones that I want you to know to feel confident in your preparation.